Hello, everyone. Good afternoon. This symposium addresses a very special issue, which is not so obvious. You know that in terms of infection prevention, there have been a lot of novelties in this century regarding specifically the protection of the exit site. And if you think about it, most of the technologies and methodologies which have been developed in the first 25 years of this century were specifically related to the attempt of reducing bacterial contamination by the extraluminal route. Think, for instance, of the development of new, more effective antiseptics like 2% correxin in alcohol. Think of the technique of tunneling that we've been discussing a couple of hours ago. Think of the sutureless device, which is also another important strategy to avoid bacterial contamination close to the access site. I think also about new things such as the new semi-permeable transparent membranes and the channel-clear glue. All of these technologies were basically dedicated to minimizing the complication related to the exit site, which basically are dislodgement and bacterial contamination by extraluminal route. On the other hand, less attention has been paid during these last decades to the protection of the infusion line itself. How do we manage the hub of the infusion line? How do we use and how do we choose the needle-free connector? All of these issues are very important for infection prevention. The feeling of many experts is that lately the contamination, bacterial contamination, is more likely to happen by the intraluminal route rather than the extraluminal route. So the scope of this symposium is to focus on which are the effective strategies of management of infusion line for prevention of infection, and how should we choose the technologies that can help us in this regard, particularly the needle-free connector and the port protector. The first speaker is Giancarlo Scoppetuolo, who is very famous in Italy and also for the WoCoVA audience. He is one of the most important experts in infection prevention. He's an infectivologist himself, but an infectivologist with a specific dedication to vascular access. He's also an inserter of vascular access device. And he will talk to us, he will do an overview of which are the effective strategies for the management, for the proper management of infusion lines, obviously, specifically for infection prevention. Thank you, Giancarlo, for being here.
Thank you very much, Mauro, and good afternoon to everybody. Thank you. It's okay. And I want to thank also GBUK for inviting me this afternoon in this very interesting symposium. And the topic of my presentation will be effective management of infusion lines for infection prevention. Vascular access devices, both peripheral and central, are an extremely important tool in patient care, and unfortunately, they can lead to several complications, some of which are only inconvenient, while others may be really dangerous for patients. This is an old paper published in New England Journal of Medicine in 2003 by David McGee on prevention of complications of central venous catheters. For the first time, complications were classified into infectious, mechanical, and thrombotic. And for each type of complication, a series of preventive measures were recommended. such as the use of antimicrobial catheters, the use of subclavian vein for catheter insertion, the use of sterile barrier precaution, and the disinfection of catheter hub, among others. As you all know, this list is far from complete. Bloodstream infections related to vascular access devices are costly and prolong hospital stays. In this paper, published more than 10 years ago, the cost of a CLI-BSI is estimated at more than $40,000 or more than $58 if MRSA is involved, and the resulting extension of the hospital stay is estimated at 10.4 days. The prevention of catheter-related infections is only possible if their pathogenesis is well understood. The pathogenesis of vascular line-associated bloodstream infections is based primarily on two mechanisms: extraluminal contamination, which is caused by not proper aseptic technique during catheter insertion or management, or by hematogenous spread from a separate focus of infection, and intraluminal contamination, caused by contaminated infusions or improper catheter hub manipulation or improper infusion line management. So, CR-BSI prevention is based on 4 moments: vascular access device selection and healthcare workers' education and training, the insertion of the catheter, the care of the exit site, and the care of infusion line. That is, the care of administration set and the time, just the right time for replacement of administration set, and the disinfection of catheter hubs, connectors, and injection ports. More specifically, the prevention of intraluminal colonization is based on hand hygiene and aseptic technique, the use of needle-free connectors, needle-free extension sets, and needle-free stopcocks, on proper management of the infusion line, and on the use of pre-filled syringes for flushing and locking. And the prevention of extraluminal colonization, on the other hand, is based on hand hygiene and aseptic technique, skin antisepsis, and protection of the exit site with proper securement, channel-accurate glue, and transparent dressing, in accordance with the Secure and Protect protocol by GAVESELT. And this slide shows strategies for preventing extraluminal colonization on the left part of the slide, and strategies for preventing intraluminal colonization on the right of the slide. The use of needle-free connector is essential for protecting the catheter hub. Gloria will explain this in detail. For now, it's important to remember that they protect the operator from needle stick injuries. If based on a neutral or positive displacement, they reduce the risk of catheter occlusion by preventing black flow, and they reduce the risk of infection because the operator manipulates the connector rather than the catheter hub directly. Needle-free connector protects catheter hub from colonization or infection, but only if properly disinfected prior access. We can use active disinfection, scrubbing the connector with 70% isopropyl alcohol or 2% chlorhexidine plus 70% isopropyl alcohol. But there is no agreement in guidelines on the time of the scrubbing. How long? 5 seconds, 10 seconds, 15 seconds? On the other hand, passive disinfection with disinfection caps is more effective and more standardized, and there is more compliance by healthcare workers. The INS 2024 standards of practice provide detailed information on the rationale for using needle-free connectors, their advantages, and the absolute necessity of disinfecting them properly, preferably using disinfection caps. Among the so-called add-on devices, which must definitely be considered part of the infusion set, there are the so-called needle-free extension sets and needle-free stopcocks. They allow simultaneous infusion of compatible fluids via a single vascular access device, peripheral or central. They may have neutral needle-free devices or a split septum design needle-free devices. They ensure a secure connection, reduce manipulation, and minimize the risk of leaks and disconnection and misconnection or premature loss of vascular access. They add length for safe handling of the infusion systems, decreasing movement manipulation mostly at the peripheral intravenous catheter hub. But before accessing the add-on device, we should disinfect the hub with active or passive disinfection. And these concepts are very, very well summarized in the INS 2024. Another very important topic is the time of replacement of administration sets. We have to replace primary and secondary continuous administration set used to administer solution other than lipid, parenteral nutrition, blood, and blood products at least every 7 days, or when clinically indicated. For example, any loss of product integrity, such as contamination or dysfunction. On the other hand, we have to change intermittent primary and secondary administration sets every 24 hours. Catheter flushing and locking are absolutely essential procedures for preventing catheter occlusion, but they can have a risk of infection. According to INS 2024, these procedures should preferably be performed using prefilled sterile single-use syringes containing normal saline, 1 per patient. The use of prefilled syringes instead of large bags or bottles prevents CRBSI and catheter failure, save time for syringe preparation, and aid to apply an optimal flushing and locking technique. This is a paper by Professor Sergio Bertoglio published in 2013, and it clearly shows for long-term totally implanted catheters that using prefilled syringes reduces the rate of CRBSI. But what about prevention of extraluminal colonization? According to Gaveseld recommendations published in 2024, the exit site of a venous catheter should be covered and protected with a transparent dressing, preferably one with high breathability and, in this case, high MVTR. Transparent dressing acts as an antimicrobial barrier, protecting exit site from colonization from outside and finally protecting the device. The exit site can be covered also with gauze tape, but only a second choice for very limited periods. And high MVTR confers to the dressing more breathability, less humidity under the dressing, less injury, and less risk of infection. Transparent dressing allows visualization and monitoring of the exit site, confers more effective catheter stabilization than other types of dressing, preventing the in and out movement of the catheter itself that promotes infections and thrombosis. If the dressing has a high MVTR, it keeps the skin under the dressing dry. Gauze and tape dressing should be used only in cases of intolerance to transparent dressing, in case of MARSI, in case of bleeding or serum loss from exit site. In this last case, we have to apply cyanoacrylate glue on the exit site to stop bleeding and to stop serum loss. Gauze and tape should be replaced every 2 days or immediately if it is dirty, torn, or wet, and should be used for very small periods. The advanced or cyanoacrylate glue, that is one of the most important innovations in the field of vascular access since many years, are several. First of all, the glue prevents bleeding at the time of insertion. It contributes to a good stabilization of the catheter. And third, but not least, it is very, very useful to seal from an antimicrobial point of view the exit site. And sutureless devices, cyanoacrylate glue, and transparent dressing with high MVTR are the key parts of the so-called secure and protect protocol by Gaveselt to be used at the time of insertion. And thank you very much for your attention.
Thank you, Giancarlo, for this rapid but very complete survey of what are the technologies today. And now Gloria Ortiz will take the stage. You know Gloria for the previous WoCoVA conferences. She's also part of the scientific committee of these conferences. She's also partly responsible of the program of the Congress. And in this symposium, she will get somehow into the detail. If the main concept are the one expressed by Giancarlo, and now getting into practical, Gloria tells us how to choose specifically two key technologies, which are needle-free connectors and port protectors, always oriented in the field of infection prevention. Thank you, Gloria.
Thank you, Mauro. Thank you, Giancarlo, for the brilliant presentation as well. Hi, everybody. I hope you enjoyed the paella. Was it good? Yeah, that's typical Valencian. Okay, so today I'm going to talk to you about the device selection for a safer infusion therapy. Don't turn off the lights. Just let me see, because I want to ask you something. How many of you here today are able to select the devices that were to work with? Raise your hand, please. Okay, many of you. So, because you are responsible for this selection, it's mandatory for you to understand the technology behind all the devices, at least those for vascular access, right? So today we're going to talk, as Mauro said, about needle-free connectors and passive disinfection cups. Let's see, why needle-free connectors? Do we need to talk about that in 2026? Yeah, I think so. I don't know what about you, but here in Spain sometimes we see vascular access lines that have no needle-free connector very often. So the primary goal for the needle-free connector years ago was to avoid the needle stick injuries and to avoid, as you can see in the picture, the need to tape needleless in place. So guess what? Sometimes I still see this in hospitals. So this is not acceptable anymore. On the other hand, using the needle-free connectors is also for working against reflux that may lead to an occlusion of the line. So the reflux can occur also for external factors that we are not able to control, as body movements, coughing, sneezing. So that's why we need to have the needle-free connectors. And it's not something that I'm saying, just like Giancarlo noted, it's something that has a one-level strength on the INS 2024. So we have evidence that this is needed, and this is what we have to use for our lines. So how to decide? You have seen here today a large and long corridor with plenty of industry partners, with so many devices. How to choose among all these materials that fortunately we have today thanks to the innovation development? Well, there are mainly four things that you need to understand about the internal functioning of the needle-free connectors. Those with negative displacement are the less effective. The blood is withdrawn back into the lumen upon disconnection, and this kind of needle-free connectors will require you to close the clamp before you finish the flushing. The positive displacement retains a small fluid part inside the reservoir that pushes forward on the disconnections, but again, clamping is, for this kind of needle-free connectors, recommended. On the other hand, if you have neutral displacement, these needle-free connectors are designed to minimize the fluid movement and to simplify all the maneuver. And for this and the anti-reflux technology needle-free connectors, the clamping is not needed. Also, the split septum technology is important when talking about needle-free connectors because it's the simplest way to design a needle-free connectors. We don't have any mechanical part inside the device, so no having moving parts. We have a pre-pierced silicone membrane that opens once we have the syringe or the infusion going inside, and that's self-closed once the connection is, the disconnection is done, sorry. And also, it is very important for infection prevention because it has a flat external surface. So really split septum technology is quite good. So as Giancarlo said, you have many options nowadays, so it's not acceptable to not use needle-free connectors anymore. This is so important that we have these add-on devices that have the needle-free connectors already on them. So here, the thing that you need to understand is really how they work. So what would be, if you have a Christmas list, what would you ask to Santa to bring you for regarding needle-free connectors? Well, I will ask for an external surface that has a split septum with the minimal external grooves or ridges, an internal geometry that has a minimal dead space, the minimal internal complexity, less is more in this case, a transparent housing. This is very important because it allows us to visually verify that we are doing a good flush with our syringe and detecting clots as well. And the mechanical behavior and neutral displacement mechanism, we have said that it's fantastic, and also the anti-reflux, but I place some question marks at the end because sometimes this technology can be a little bit more expensive, and sometimes it's also for us dealing with costs as well. So the point is that we need to make a good selection, a good choice between the cost and the effectiveness of the devices. So regarding the time that we need to apply the disinfection, as Giancarlo said as well before, it will be much easier if we have a flat surface and the correct needle-free connectors. It will be much easier. Although the time for the scrub is needed, of course, having a clear housing and having a flat surface will help us to make a much effective disinfection. So let me go a little further. Okay, the passive disinfection cups is really a very good tool for improving safety and for controlling the risk of infection in your facilities. So we have also many studies that talks about not only how this kind of devices work, but also how they standardize disinfection. This is something that I think that we need to achieve, right? Because I have seen so many different ways of disinfecting hubs. I'm sure that you also have seen it with different disinfectants, with different, I don't know, maybe a gauze or maybe another thing, a piece of cotton. I've seen almost everything, I think. So also having this kind of devices help us to standardize something. Having them close to the bed of the patient also allows the patient to gives you to make you pay attention to that, because they see that you need to put those devices on the line. So sometimes are the patient themselves that are asking you to put that device on the line. So they are a physical barrier against the external contamination. They usually have isopropyl alcohol, but as Giancarlo said, we can also find some with chlorhexidine together with alcohol. But the good thing about these kind of devices is that they penetrate the surface of and the irregularities that we can see on the surface of the needle-free connector. They usually are color-coded designed, so this is for us and also for the patients. It's a call to attention, so we can see instantly, immediately, if it's been used or not, and give us the feedback if it's in that the hub is disinfected. And the effective protection is maintained up to 7 days if undisturbed, and it's a single use only. This is important as well. You cannot take it off. make it wait on the table, on the patient's table, and then reuse it, okay? It's one per every time that we are going to access the connector. And also they are very easy to connect and disconnect. They are, of course, very effective for the disinfection of the surface, but they need to work together with the antiseptic no-touch technique, because it doesn't worth it to use them if after that we remove them, we replace the line on the patient's arm or on the bed, for example. So these cups need to be used together with the antiseptic non-touch technique. So why are they so good? Because it's been said that the use of isopropyl alcohol reduces the bacterial reduction with this kind of mechanism if compared with the manual gauze and the ethanol in almost half. So having more than 80% of bacterial load reduction if compared with manual gauze, and we have almost 50. And the scrub the hub compliance is not something that we all do correctly. Giancarlo mentioned it before that the time for scrubbing the hub still has no consensus, but you can find some studies where they say that the recommended duration for the scrubbing is 15 seconds. Do you know how much is 15 seconds? It's a happy birthday. Happy birthday to you. Okay, if you sing that, more or less, those are 15 seconds. Are you really going to sing happy birthday to you every time you're going to access your port? Do we have that time as nurses? It's hard to accomplish, right? So having this kind of devices allows us to be free of singing happy birthday, other than if it's the patient's happy birthday, of course. So, and on the other hand, it's been seen and demonstrated that these devices are cost-saving for the hospital and the facilities. As nurses and as the responsibles for the selection of the devices, this is also a consideration that we need to take on. So the manual disinfection requires the manual friction. We have the human factor. And if we have the human factor, we can have the error as well. They are immediately exposed. The needle-free connectors, if scrubs only with the gauze, as I said, they are exposed to the environment. And we need to be very careful with the antiseptic no-touch technique, and they have absolutely dependence on the human maneuver. Also, doing the manual disinfection sometimes is not good enough for make disinfection of the irregular surfaces of the needle-free. And of course, this is something that works, but as usual, and Mauro is the one that have teach us all that bundles are the best solution for minimizing complications. If we use needle-free connectors, if we use pre-filled syringes, and if we use the passive disinfecting hubs, we probably are going to have a very good bundle based in evidence and data that will help us leading with the intraluminal infection of the catheters. So, in conclusion, the best design for a needle-free connector will be the split septum, the transparent housing, the neutral displacement. The passive disinfection cups are effective and they significantly outperform manual scrub the hub compliance. Knowing attributes and limitations of the devices is critical in making decisions for protocols and care practices, and it's also our responsibility. If we want to be called experts, this is also our field of knowledge. And finally, need of bundles. Bundles work fantastic for nurses, for make a summary of the evidence, for make these indications easy to remember, easy to learn, and easy to apply on your daily practice. So this is the reference, these are the references that I've used for this presentation. Thank you, GBUK, for the invitation, and thank you for the attention.
Thank you. Before a few questions, we have time for a few questions from the audience. Before that, I have one question for Giancarlo, one question for Gloria. Gloria talked about the human factor, and I would like to ask Giancarlo, how much this is relevant when you enter a new technology in a clinical setting? I mean, probably the nurses or the doctors should be persuaded that that technology is good, and also they should be trained to use it, and they should see this technology in a wider a picture of strategies. Can you comment on that? Can you clarify that, please?
Yes, very good question, Mauro. Thank you for this. I think that human factor is the main thing that we have to consider to have a winning strategy. You know that Johns Hopkins University, in his view of this problem, the problem of introduce a culture of prevention in hospitals, underlines that the first step for this process is the engagement of healthcare workers. So healthcare workers must be convinced on the importance of the problem of infection prevention. And after that they are convinced on it, they must know the technologies, but only to introduce the technology, as Gloria told at the end of presentation, in a well-structured way to solve the problem, that is the bundle of intervention. You all know that the philosophy of the bundle is a winning philosophy. If we have technology, if we had spot interventions, but we have not the possibility to put all together in a list that must be applied for every patient by every healthcare worker using the best technology that we have available, the job doesn't work.
Thank you. And talking about, always about human factor, that's a difficult question for Gloria. But it's not difficult for her because she's a matter, a field where she feels quite comfortable, the patient. I mean, the patient is not an inert body, and how much could we rely on the patient's collaboration in having these technologies appropriately employed? I make an example. In my hospital, for instance, we use pore protectors, and we use pore protector for children, and we have taught to the parents of the children that each hub should be protected by one of those disinfecting cap. So even if the doctor or the nurses do not put attention, it's the parent that remembers that that line is protected if there's a disinfecting cap. This is a small example of how the patient or the caregiver can be somehow making themselves responsible, or at least cooperating in these strategies. What do you think?
Yeah, right. Correctly. That's exactly what I mean it. When I was working in Madrid together with my colleague Teresa, I know she's here in the room. We made this kind of experiment as well, because we were really collecting the data on how often were the ports protected with these passive disinfecting cups. And we saw that they were very much used, because we decided to use not only to have the cups where the nurses were, but also where the infusion were. So the patient knew they were very colored, and the patient knew that every time the infusion wasn't on, they need to have one of these cups on the port, protecting the entrance. So, and we saw really that the adherence from nurses and the existence of these cups on the ports were really very high, between 90%. So it was really easy, and on the other hand, you had the patient, as you said, not only the parents, but the patient themselves. Of course, they need to be oriented and collaborating. But sometimes they were asking you, look, I don't have this on my line, so I know that I have to put one of this, would you? So I think it's also about empowerment under that point of view. We are always talking about the patient needs to be at the center of the process. We need to inform the patient. But the truth is that sometimes we don't like that the patient tells us what to do. But in this case, I think this is very good and positive, not only for them, but also for us. They are saving us time, and they are giving us really, how can I say, they're knocking out outdoors saying, look, you missed this. And they're involved in the process, what I think that is really good for them. Yeah.
Yeah, and sometimes the patient is informed previously because he's already conscious of what we are doing, because he watched that thing on YouTube or internet, whatever, and there is always the risk that he is going to judge us. In this regard, how good, Giancarlo, is the video? The video training, the video examples for the operators, for the nurses, for the doctors of the hospital.
You know, Mauro, and we agree totally on this, that video and video training are a fantastic tool to train the healthcare workers, and not only the healthcare workers, because the video is simple, is immediate. It takes a very little amount of time. You know that in our hospital, for the information of healthcare workers on this topic, we are using a video and not a classical presentation. The classical presentation is noisy. The classical presentation it's not good because it takes a lot of time. The video is able to stress the real important point. It's really important to show and not to say what do you have to do. And this is very effective. And it's very effective also for relatives, for parents. Because if you show to the patients and to relatives of patients the right thing to do, they are better than healthcare workers. So the video can have a very, very great importance.
Yeah, we have a project going on, as you know, of making videos for the caregiver, which at home wants to know exactly how to manage an infusion line, how to manage the access site. And that's a very powerful tool.
Yeah. Now, just a second. We are improving in our hospital an OPAT program for patients. And of course,
outpatient antimicrobial therapy.
Yeah, outpatient parenteral antimicrobial therapy. And we need something that is really useful to train the caregivers. Also for the central line or peripheral line, but line by which we train the caregivers to administer antibiotics at home.
Yeah, this opens a very interesting wide field of future development in training and in quality improvement. We have time probably for some question of the audience. Do you have a specific question on this issue? Did you have a...
Would you mind if I make a little...
First a question.
Okay.
Thank you very much. Question for Gloria.
Yes.
I'm Paul from Wales in United Kingdom. You're with Neva's team as well. We looked at the end caps for all our lines, and we estimated we need at least 500,000 per year. And then I was asked a question by my carbon footprint department. How do we deal with the disposal, and have we included the cost of disposal in the business case for the costings? And I said, no, I haven't.
Wow, that's a hard question, not the one that Mauro made to me. Well, I think that under that point of view, you're right, because the devices are done with plastics. So I'm not an expert on the field about the carbon fingerprint that we will have. But of course, this is something that you need to be aware of, because many, not only hospitals, but also companies have been punished by the government if they have a higher footprint and the carbon and all these kind of things. So I really don't have an answer for you, but we have here the colleagues from GBUK that probably can give you a more accurate answer. I'm sorry, but I'm not an expert on that. But
okay.
of course, this is something that we need to consider as well. I have seen in many hospitals here in Spain, maybe something common in Europe, but here in Spain it's more often common to see inside the wards the, I don't know how to say this in English, the selection of the refusal material, like plastic and paper, and this is a procedure that hospitals are obliged to follow nowadays, and it's not included in all the hospitals, at least in my country, as I said. So I think that your point is fantastic, because we need to consider the environment as well. But I don't have an answer, honestly, frankly. I don't want to say something that's wrong.
Thank you.
Thank you for this question. On the lighter note, if thermoplastic is completely avoided, we can also stop to think about vascular access, because the whole world of vascular access is based on the use of thermoplastic. So probably in 2 years we will not have any WoCoVA if the thermoplastic is prohibited. Okay, thank you, and we are exactly at 2 o'clock, and we have to leave the room for the next session. Thank you very much for your attention, and thank you to Gloria, to Giancarlo for sharing their knowledge with us. Thank you.